I'm going to introduce Dr. Casey Halpern as well as his colleague, Dr. Q. But first, Dr. Halpern's clinical practice focuses on the surgical treatment of movement disorders, including Parkinson's disease, essential tremor, Tourette syndrome, and dystonia. He has a particular focus on early onset Parkinson's disease using DBS and focused ultrasound. Dr. Halpern also leads a translational neuromodulation laboratory aimed at expanding the field of stereotactic and functional neurosurgery to obesity, obsessive compulsive disorder, addiction, depression, and other psychiatric conditions. Dr. Halpern completed his internship, residency, and fellowship at the University of Pennsylvania. He spent 9 years at Stanford before returning to Penn Neurosurgery in 2021. And with him, who will be presenting a case later, will be his coworker, Dr. Liming Qui. She completed a residency in neurological surgery at the National Neuroscience Institute in Singapore and attained specialty accreditation. She then underwent a 2-year postgraduate fellowship training in stereotactic and functional neurosurgery at the University of Pennsylvania. Dr. Q's clinical expertise includes deep brain stimulation and focused ultrasound for movement disorders and neuromodulatory management of chronic pain disorders. We're so grateful you're here today. Without further ado, I'm going to let you take it away.
Eden, thank you so much. Can you hear me okay?
Yes.
I know that Dr. Q is doing a case right now, so she'll be joining us in a little bit, and I'll cover until then. Let me bring up my slides here. Can you see that okay?
Yes.
You see me in the middle there?
Yes.
I can see the window, but if anybody wants to interrupt me or just chime in, because I might not see your face, or if there's any chats, Eden, or anybody raising their hand virtually, just let me know and we can always pause. This is the team. I can't do anything without my team. I do have a little bit of an entourage. I believe in an entourage, but it's because the members of the entourage are so critical to your care. On the left, you'll see Gabby Gratton. She is our DBS coordinator, our navigator, and kind of what I call the answer. Quite literally, she answers a lot of phone calls, but she also has supported the team in ways that we've really needed for a long time, mostly because our patients need somebody to help navigate them from beginning to end. Ian Cahigas is next to her. He is my partner in crime, a wonderful neurosurgeon, takes care of Parkinson's patients. He also does a lot of surgery for chronic pain and epilepsy. I'm in the middle. I'm Casey Halpern. I'm the director of functional neurosurgery at the University of Pennsylvania. I took over for my mentor about 4 years ago now, Gordon Baltuck, returned from Stanford, as Eden mentioned. And this is a program I could not be prouder of. I train fellows, so my surgical assistants are fully trained neurosurgeons. We recruit the best fellows from all over the world. Liming Qui was one of them about 3 years ago now. She is arguably, if not undeniably, the best fellow I've ever trained. And, sometimes you get very proud of your trainees when they surpass you in skill and knowledge. And she's really one of those people. Denise Miller on the right, our nurse practitioner, is the best clinician I've ever worked with. She is the primary physician, although she's a nurse practitioner, so I should say a primary care provider for a number of chair people all over the health system because she is so good. And I had to compete for her as my nurse practitioner with my own chairman because she was so sought after. Suffice it to say, I have a great partner in the clinic as well, Denise, who can help take care of you so I can focus on your surgery. Today, I'll be talking about Penn's Rescue Clinic. A DBS rescue is not something that you can pursue in most places. Most neurosurgeons are unwilling to do rescue procedures or revisions. We have a one-stop shop program built on substantial expertise collected over the years with a lot of success. I've never really had a chance to talk about it formally, so Eden, I'm really glad to be able to do that today. And so, give me some feedback, let me know how this goes, and I look forward to helping anybody who feels they need any kind of rescue. And let's talk about that a little bit. I think it's really important to recognize that people that need a DBS rescue probably have been put through the ringer. You've probably been to your neurologist many times, to your neurosurgeon many times. You're probably quite frustrated. I really try to make this experience white glove service, direct to surgeon. Just come in and let's have a conversation and figure it out. And I'm going to give you a good experience while you're doing that. So why do people come to our rescue clinic? People come when they're dissatisfied. People get deep brain stimulation. They have high hopes for success, but the stimulation is not working out as expected. Maybe the benefits are not as good as you expected. Maybe there's a lack of benefit. Maybe things are worse, or there's side effects that are making the overall benefit intolerable. Maybe you can't get into your neurologist enough. You feel like if you got programmed more, you get better outcomes, but your neurologist can't see you enough. Maybe you were told deep brain stimulation is not an option. Maybe you haven't even had the surgery in the first place, but you're looking for a second opinion. That's where our rescue clinic comes in. We want to be immediately available to our patients, people that are in need, feel like the medical field is not working for them, and we want to fix your problem. Of course, the biggest risk, I always tell this to people, the biggest risk of coming to the rescue clinic, that there's nothing I can do to help you. But at least you're getting a definitive opinion from somebody, a second opinion. I do my own rescues when necessary, by the way. Sometimes it is a critical thing to do, and patients that don't do well with deep brain stimulation really deserve a chance to figure out why. So if you want to come and see us, you have to send us records. Gabby, our navigator, will help navigate that, coordinate from your house where you live to seeing us in clinic. It could be a telemedicine visit, an in-person visit, and we will be spending some time with you to assess history, expectations, what happened with the DBS at the time of surgery, what happened with the programming, and then we would evaluate the programming settings as well. I want you to think of this as a getaway. Take a moment, and I hope you haven't given up on your outcome, and give us a chance to make things better for you. And I can tell you, having had a number of patients go through this process, some of them really feel like it's a getaway because all of a sudden there's hope and we have a lot of experience. So they're around a team that feels very relaxing and lots of benefits to come from that. So I like to think of this as a getaway. Now, we might not be taking you to the Caribbean. We're taking you to Penn Princeton. We're taking you to Pennsylvania Hospital in Philadelphia. We do see patients in Radnor, Pennsylvania, Lancaster General Hospital. So not quite the Caribbean, but it'll be a great experience, white glove service. So this is the inspiration. Deep brain stimulation should really work. But if it's not working for you, my gosh, you've undergone a brain surgery, you have a medical device implant, both in the brain, the neck, and in the chest. You really deserve a chance to figure out why and do everything in your power to get it working again. So I'm going to spend the time here trying to help you get that outcome that you expected. At least 90% of people feel that deep brain stimulation is extremely helpful. So when I hear that somebody says it's not helpful, the first question I have is why? So there's technologies now that allow us to answer this question. This is image-guided programming. So that means that I can take your MRI or your CAT scan and look at your deep brain stimulation system and figure out how to optimize or improve your outcome by using the stimulation guided by your MRI scan. And you can see here just an example of how I can actually tune your stimulation by looking at your brain in 3 dimensions. That green structure is your subthalamic nucleus. And here I'm actually able to steer the current in the direction of that nucleus by using your imaging. So image-guided programming is a technology released by Boston Scientific in their collaboration with BrainLab that really allows us to do these rescues more aggressively now. The other type of technology that we use for these types of rescues are simple adapters. These are tiny little filaments that connect to the system that you have that allow us with a minimally invasive procedure to connect you to a new latest and greatest technology, a new battery that offers you ability for personalization of your stimulation. We have a lot of experience actually taking old batteries and replacing them with these newer batteries to actually improve your result. And so patients who are having side effects from deep brain stimulation or lack of benefit could actually swap out their battery for a new battery and actually get improved outcomes. We've actually found that if we take a old Medtronic system, for example, patient feels like they're having side effects. We take out the old battery and put in a new battery. The majority of patients are seeing improvements in stimulation efficiency, meaning you're able to tolerate a higher dose of stimulation and get more therapy. And the majority of patients are seeing clinical benefits, improvements in tremor, improvements in side effects by just a battery swap. Some would call this an upgrade. So if you're dissatisfied with your DBS, we have new technologies that allow us to better evaluate and give you access to the latest and greatest to try to improve your outcome. However, let's take a step back for a second. When somebody calls in and tells me they're dissatisfied, the first question I ask myself is your diagnosis correct? Was the indication for surgery appropriate? You say you have Parkinson's. Do you have Parkinson's? Do you have a different diagnosis? So we review your history, we review your diagnostics, we review the medication you were on previously, your physical exam. Sometimes we do on-off testing with Cinemet. We evaluate where the electrodes were placed, the choice of the DBS target. This is the first question to ask in our rescue clinic. So, for example, maybe the answer is no. Maybe you have Parkinson's disease, but you have one of these Parkinson's plus syndromes. And if that's the case, we wouldn't expect deep brain stimulation to be very helpful. And that could explain why you're dissatisfied. And I would offer you removal of the system. There's other times when people have other diagnoses, like essential tremor. And in that case, perhaps deep brain stimulation was appropriate, but maybe a different target is needed. So then you might need a revision surgery. Assuming your diagnosis is correct, so if you have, let's say, Parkinson's, as you expect, then the next thing to do is to evaluate imaging. So we can do image-guided programming, as I showed you earlier. So when we get that MRI, it's also nice to have your CAT scan. We evaluate how the electrodes were placed. We evaluate where they are in your brain. We review the effect of the stimulation. Sometimes I do some modest programming to confirm placement. For example, if a patient says to me at a high dose, I get side effects, I actually like to see what those side effects are in my clinic, because that helps me confirm where those electrodes are placed. There are times when we can take a system and reprogram you and actually improve your result by using image-guided programming. Historically, we use symptoms to guide programming, and that was perfectly valid. But we like to use your MRI scan to guide programming and then see its effects on your symptoms. It seems like this works more efficiently and actually leads to better results. What if when we're doing programming, however, there's side effects? Maybe the tremor gets better, but you have really bad slurred speech. Turns out, with a simple battery swap or upgrade procedure, we can actually improve on those side effects and improve on that outcome, because the latest and greatest technologies allow you to personalize the therapy and what we call improve the side effect threshold, make it so we can give you more therapy without causing side effects. However, it's also possible that when we go to reprogram your device, that nothing works. Maybe the effects are intolerable. And then you might need a revision surgery, a rescue surgery, where I would place the electrodes in a different part of the brain, a new target perhaps. Or I would remove the electrodes that you have and revise placement. And of course, that does require additional surgery. But again, this was a procedure that you chose to have. And if it fails you, and there's an explanation as to why it fails you, we need to fix it. I want to go through some cases with you to help illustrate what we do. So this is a 68-year-old male. Some of you might relate with this. Had surgery over a decade ago using the precursor Medtronic system. He was due for battery replacements every 3 years, wanted a rechargeable battery. So we offered him a rechargeable battery some time ago now. Let me show you how we did this. So we actually took the Medtronic settings, which are in the middle of this screen, and we converted them to, in this case, a Boston Scientific device. Exact same settings. So if I kept him on these exact same settings, you would expect the exact same result. And in fact, for the most part, that's what we got. However, when the patient woke up, we were able to fine-tune the stimulation. So I used to say that, and the analogy here is one size fits all. Deep brain stimulation used to be a one-size-fits-all therapy up till about 5 years ago. And more recently, we're able to personalize it, customize it. And because we can customize it, our outcomes are better. Of course, there are times when one size fits all, we nailed it. You know, you had a great result, and then there's no way to make that better. But sometimes the result was subsatisfactory. And if that were the case, these more personalized strategies allow us to actually improve the therapy, decrease the side effects, improve your balance, for example, in this case, and get you more therapy. We were able, within one programming change, to increase this patient's dose from 3.2 milliamps to 3.8 milliamps. We did the same thing on the right side of the brain, able to increase the dose, improve the therapy, personalize it, and titrate it in ways to decrease side effects. Really, really important opportunities. And these just required a battery swap. No other surgery was done in the brain. We can even do this remotely. So you can actually be home, and I can actually tune your system based on your imaging. And in this case, we're programming. You can see there's a little bit of tremor left over. But with a review of the MRI scan, all done remotely, here you can actually see here. This is a programming session. You can see the tremor in the foot. This patient is at home. This is technology, latest and greatest technology.
That was
It's
actually a
always,
question in the chat. Can you do
yeah,
remote setting adjustments to improve results? So you actually can do this remotely.
it depends on the system that you have, but it is certainly possible. Sometimes the patient can be home. Sometimes the patient can even be in their family doctor's office, for example, and I can program from Penn. Sometimes people don't like to come into the city. So if they go to their local doctor, we can actually program you there. So this is an example of a patient who was having a reasonable outcome, but there was still some tremor there. So we reviewed the MRI scan, and you can actually see here, all done remotely. Even at a lower dose, we were able to get that tremor under control. And this patient didn't even need to come in and see us. Of course, we prefer to see him because we like people, but the convenience here was so huge for this patient. He was an elderly guy in his late 70s who lived about 2 hours away. So what if the surgery, we evaluate your MRI scan and I tell you, it looks like your electrodes are a little off. They're not optimal. What do we do there? So what if you're not a surgical candidate, for example? What if you can't get more surgery? Maybe you're in your 80s. That's where we have to take on some advanced programming techniques. We use image guidance and other strategies to improve your outcome. Also include setting expectations. It's possible we might not be able to make it better. Remember, I told you the biggest risk of coming to see us in a rescue clinic is that we can't make it better. Of course, if you are a surgical candidate, a revision might be possible. Let's look at this patient. So this was a 84-year-old individual, came to see me with Parkinson's suboptimally treated. And I did an MRI scan and a CAT scan. And you can actually see it here if you look carefully on the top of the screen, also on the bottom of the screen. That wire is not in the sweet spot. If you look at the top of the screen in green, that's the subthalamic nucleus, that little oval-shaped structure, and the wire sitting next to it, not in it. It's that simple. That wire has to be sitting within the subthalamic nucleus in order for you to feel satisfied with your outcome long term. However, there are circumstances when we have to get creative. This was a patient who we saw, and I want to thank Jamie DeChico for helping me prepare this slide, who was not a surgical candidate for a revision. He really wanted me to do a revision, by the way. But I said to him, listen, it would be an aggressive surgery. We might be able to get you better by doing some pretty unique programming strategies. Here you can see what we did was we activated every electrode, all 4 contacts, and we're able to actually rescue this patient's outcome. I have to say, I've been practicing now for over a decade. This was one of my most grateful patients. We were able to get his Parkinson's symptoms better. We were able to lower his medications by titrating the current and spreading it across all of these contacts. This was something that was unique and something that's rare because in general, if an electrode is found outside of the target zone, I would recommend revision. But in this case, since we weren't able to revise, I was very proud to be able to get this patient such a positive outcome. Here's an example of a case where that wasn't possible. This was a patient who I took over programming for. You can look carefully here in the middle of the screen in particular. You can see that green oval shaped, and you can see that the electrode is in it, but it's below it. And in this case, the patient was having intolerable dyskinesias. In fact, I did a webinar with him on it just like this once, and I saw him on the screen bouncing around. I could barely keep him on the screen when I was talking to him. And we offered him a surgical revision. And there's a couple of ways to do these revisions. You could potentially simply just pull it back. You could also potentially completely change where those electrodes are oriented. But either way, if you are a surgical candidate and the wires are not considered optimal, I would recommend a surgical revision at this point. And we were able to really get this guy a much better outcome. And he's a young guy. We wanted him to have an optimal therapy for the rest of his life. Now, there are, as wonderful as deep brain stimulation can be. Oh, and I see, by the way, Ian, there's a lot of people on with a lot of chat, so I'm happy to take on some questions if it's helpful. But sometimes we need to resort to other strategies to rescue your deep brain stimulation outcome, and that's focus ultrasound. Did Dr. Q, was she able to join us even?
She is here.
Liam,
Dr. Q, if you'd like to come off mute.
Eden, while Leeming's coming on, should we
Okay, I
go
have
through?
a couple of questions. Somebody asked, can image-guided programming be done with Medtronic Percept?
So I think it's important to recognize that image-guided programming is a technology that was developed by Boston Scientific. It is automated with Boston Scientific, meaning you can actually use image-guided programming on the programmer in the clinic with the patient.
Mhm.
However, we do use image-guided programming, whether it's with Medtronic or Abbott. It's just a little bit logistically challenging. We have to bring up a separate tablet and review your imaging. It's not done as seamlessly, but yes, it is possible, and we do it all the time.
And then someone asked, I thought mixing and matching DBS systems was discouraged because it breaks the warranty and the technology doesn't work well with each other. Is that not true?
So it breaks the warranty with the original company, but you are fully warranted with the new company. So if I can tell you, since I have done this for a very long time, there has never been a patient who did not have a warranty on their system. But yes, you might lose it with the original company, but you'll have it with the new company. And that is a scare tactic that you might hear. I would encourage you not to listen to salespeople too much. There are neurologists and neurosurgeons that are reluctant to do these hybrid systems. And the reason for that is because you historically would lose MRI compatibility. It turns out it is now MRI compatible to do it.
Mhm.
So these types of hybrid systems are getting less and less discouraged. It's important to also realize that a lot of my rescue work was done at a time before Medtronic had a newer system. And it is possible that a rescue can be done with Medtronic's battery as well, but I have much less experience doing that. It doesn't mean it can't be done, and I have done it before. It just depends on the situation. Every case is a case by case basis. But but certainly a hybrid system is possible, it is safe, and it is now MRI compatible.
And do you have a different approach based on the different manufacturer as to what you can do?
Yes, each manufacturer has its own advantages and disadvantages. For the most part,
Mhm.
these devices are more similar than they are different. There are some nuanced advantages and disadvantages that are things that each patient should be aware of. But I think the critical decision that patients make are whether they should get DBS or not, or if they're going to get a DBS rescue procedure or not. Once those decisions are made, additional discussion around which device should be had. But overall, the device choice is, I think, a secondary part of the conversation. At Penn, we use all of the devices. We're very proud that we have a lot of experience and expertise with all of the devices. There are hospital systems that will only use one because of contract restrictions, but we do not allow for contract restrictions at Penn with deep brain stimulation devices.
And then over time, do the target areas change?
Over time in one's life, the target area can change. So yes, I used to practice at Stanford University. The question sparks, this brief story I'll tell you. I saw a patient who was implanted. I was at Stanford, UCSF is very close by, and actually one of my greatest colleagues, Paul Larson, used to practice there. And I saw a patient of his, and I was a young neurosurgeon. He was a very senior neurosurgeon, and the patient had subthalamic nucleus deep brain stimulation for tremor, but was suffering from a lot of dyskinesia. And I remember calling Dr. Larson and saying, listen, I think this patient needs a rescue procedure. I, I'm kind of curious why you didn't use the globus pallidus. And he said, well, truthfully, Casey, at the time, we had a lot more subthalamic nucleus experience and he didn't have dyskinesia. But now it seems like he is a better GPI candidate. You should feel very comfortable pursuing it or send him over to me and I'm happy to do it. I ended up doing the surgery myself and he did very well. There are times when patients get implanted somewhere, and that might be why they need a rescue, because over time their disease evolves and their needs change. Or maybe perhaps the first surgery helped but didn't help enough. And we are also very interested in our rescue clinic we're very interested in multi-targeted deep brain stimulation. So that would mean a wire in both the subthalamic nucleus and the globus pallidus, since they have complementary effects.
Thank you. And someone's asking, what's a realistic time frame that we can expect DBS to work for PD symptoms?
So I place the battery separately from the wires. The reason for that is that it undoubtedly lowers the infection rate from the surgery. But because that's inconvenient, I try to make up for that by activating the battery on the day of the battery placement to save you a trip back. And the large majority of my patients, when I activate them that day, see some benefit. But the real benefit doesn't usually come for about a month or two after that. So I usually quote patients that they should wait for about 3 months to see a significant improvement.
And going to invite Dr. Q to join us to come speak, come off mute. That is for the general questions. There are some very specific questions in the chat that I'm not going to ask Dr. Halpern. You can reach out to him, but he cannot give any sort of medical advice or anything on this chat. So I'm not going to ask him the super specific questions. If you're wondering why I didn't, I'm not ignoring you, but I can ask case specific questions and he really can't comment on that. So thank you, Dr. Halpern. And Dr. Q, would you like to come off mute?
Just give me 1 minute.
Okay.
Hey, Dr. Q.
When do you typically, I'm trying to understand this question. When might a DBS become available? I don't know what a DBS is.
ADBS is a abbreviation for adaptive DBS,
Okay.
which Medtronic is trying to release in the near future. Unclear exactly how near that is. I really don't know how much time it will take. I could see it taking a year. I could see it taking 3 years. I'd be surprised if it's sooner. Um, the theory around adaptive DBS is that there might be a biomarker that the device can detect that can better guide the therapy, maybe increasing it when symptoms are bad and decreasing it when symptoms are quite good in an automated fashion. There is some evidence that this is effective, but unclear if this is going to be a game-changing technology, but it's certainly a technology that Medtronic is very excited about, as well as the team at Penn.
Someone asked for revision. Do you ever add two leads or do you remove and replace?
Great question, and it really does depend on the patient's problem. You know, if you have STN, deep brain stimulation, and you're getting a lot of dyskinesia, I presented a case where I found that the electrode was a bit deep, and if wires are in the subthalamic nucleus a bit deep, they will worsen dyskinesia, and it's very hard to get it under control. So there's a variety of things a surgeon could do at that point. The wire could be pulled back a little bit, which would be a minor revision. The wire could be replaced, which would be a bit more major, or an additional wire could be placed in the globus pallidus because that works very well for dyskinesia. And the reason to do one or the other would be made on a case-by-case basis.
And I believe you've covered those. Do you do awake or asleep DBS and which is better for rescue?
Depends. Gosh, you know, it really is a case-by-case basis. It really does depend. In my clinical practice, I do deep brain stimulation surgery awake or asleep all the time. I do recordings in the brain for both of those scenarios because I think it's an important tool to improve outcome and accuracy. Um, for revision surgeries, I am probably more inclined to do them under anesthesia. But I don't do that always. And there are times when I do them awake as well. It really depends. The good news is that we are able to do surgery asleep if somebody can't tolerate being awake for their surgery. There was a time when we required patients to be awake for the surgery, but that's not necessary. A sleep surgery is a very reasonable strategy, but there are some advantages to doing it awake that I would offer patients if they're able.
And can DBS negatively affect speech? And if so, can it be corrected?
Yes, it can negatively affect speech. Usually those effects are minor. If they're not minor, I would generally recommend reprogramming or evaluating where the electrodes are placed. Of course, if you shut the device off, your symptoms will come back, but it would be a good test to do to see if the speech gets better, because that could confirm that the stimulation is worsening the speech. Because in Parkinson's and in essential tremor, your speech can worsen because of the condition itself. So it would be good to confirm that it's coming from the stimulation. The subthalamic nucleus as a target has a higher chance of causing speech side effects than the globus pallidus, partly because it's much smaller and in some ways a bit more delicate of a target, but it does work better for tremor in most scenarios. So we often go for the subthalamic nucleus and monitor for speech side effects carefully.
Okay. Do you have a couple more questions? But Dr. Q, if you're ready, I'll have you go and then I'll come back with more questions.
Sounds great.
Thank you.
Thank you, Dr. Halpern, and thanks for the invitation. Sorry for being a little bit late. Was doing a focus ultrasound procedure. So Dr. Halpern so far shared a lot on deep brain stimulation, which is I think what most people here are kind of familiar with. I'm going to switch gears a little bit, talk about what other procedures we could offer as a rescue for patients. To start off, I'll give an case example of one of our patients. this is a 77-year-old gentleman with tremors since 1969. He came to us actually after he had DBS placed in an outside hospital a few years earlier. So he had left-sided DBS placed to treat his right-hand tremor. So you can see here on the right side, his spirals. So right-hand tremor is a bit better than the left side, but he would like to have his left-hand tremors treated as well. However, some of the considerations we think about when patients have had DBS or are considering second site treatment is that, how they recovered from the previous surgery. And this patient suffered cognitive decline after the first surgery with just one site treatment. So there is a chance that he may get worse cognitive outcome with the second site treatment. So then for a patient like that, we think about what are some of the options that we can offer here for the patients to think about. So options that are possible could be going ahead with deep brain stimulation, but with a caveat that knowing patient may have worse cognitive outcomes than the first time, or considering other options such as focused ultrasound, gamma knife, options that doesn't involve incision, putting an implant into the brain. So in this patient that we are discussing here, our options, we explain these options to the patient as I stated here. And we have, as the surgeon, we think about feasibility, safety of, again, combining technologies. So patient already had a DBS. What are some of the safety considerations to have when you're thinking about focused ultrasound, gamma knife, and things like that? So I would say that our option, after going through a lot of details about whether it's safe for patients to have focused ultrasound after deep brain stimulation, not many people, I would say, have had this in the world. We talked to our partners, our collaborators, friends from international, and we have example of this being successful. I can show on this bottom right figure here. This is a successful case that's been treated in Korea by Dr. Chang. And he shared this experience with us because he knew that here at Penn, we've been thinking about this a lot and trying to explore the safety of doing this for this patient. So we have modeled whether it's possible to do this with the patient's DBS lead placed on one side and whether it's safe for us to do focused ultrasound. So you can see here, this is a little bit technical, but basically we calculated and found that it will still be possible to treat this patient safely. So we had to, put in a lot of applications, overcome regulatory hoops with the hospital, with the FDA. I think we are coming very close to being able to do this for our patients soon. And having the support and, a successful case from Korea to demonstrate the feasibility was very helpful. So you can see here in this picture, if just to try and orientate you, this patient had a DBS placed here, and it basically did not affect the treatment that was being planned with the focused ultrasound. And the patient had a good outcome after that in this case study. So what is focused ultrasound, you may ask? So basically, focused ultrasound is a new technology that has been around for close to 10 years now that's commercially available. It uses ultrasonic energy to heat up tissue in a very precise manner to help to treat tremors. So it's the second most common technology that we use now to treat movement disorders, especially with tremors. It is approved now to treat essential tremor as well as Parkinson's movement disorders. So what happens in focused ultrasound is that by converging 1,000 ultrasound beams, as you can see here in this picture, when the beams all come together, it heats up the tissue and destroys the tissue. So we would aim this point very carefully at where we know the tremor cells are, so that we can make a small lesion at that specific point to improve the patient's symptoms of tremor. So some of the advantages of this technology is that we can make smaller lesions, it's more precise, improve safety profile. Patients do not need to undergo a surgery if they have, higher comorbid conditions that preclude them from having a surgery. Everything is also done with real-time imaging, so we can see the temperature as it rises during the surgery. As a physician, we can stop the treatment at any time. Compared to gamma knife or radiation therapy, it has no radiation-associated side effects. It's an outpatient procedure, and there's no implant that is put in the brain. So this is a animation of how the technology is, the machine. So basically, there's a frame that is being used to hold the head in place, just like DBS. The whole procedure is done in the MRI machine. We use imaging to do the targeting as precisely as possible, and then we use the computer to control the targeting and control the beams that are being delivered to the area of the brain. So it's been in research for a few decades, but commercially available since 2016. So here is a timeline of the development of focused ultrasound. Again, as mentioned, 2016 it was approved for essential tremor. In 2018, it was approved for treatment of tremor in Parkinson's disease, and then subsequently further targets were approved, including the globus pallidum, as well as second site treatment now for essential tremor. So some of the results of focused ultrasound treatment. So you can see here just briefly, tremor severity is on the y-axis. You can see that over 3 years and even up to 5 years now, we have the longest outcome results for essential tremor. At 5 years, patients still do have significant improvement of tremor outcome, although a small percentage of patients do have a small return of tremor, and we can discuss that in more detail. Now, it's also been shown, as I showed in a timeline, that it's safe to do bilateral thalamotomies in a staged fashion. So the reason why people are concerned about doing bilateral treatment with focused ultrasound is because this is considered an ablation technique, unlike deep brain stimulation. So deep brain stimulation, as you've heard, basically it's like a pacemaker for the brain. So you deliver electricity to the area of the brain to try and suppress the activity. And by doing so, it suppresses the movements, or it improves the movements accordingly. Now, for ablative technology like focused ultrasound, instead of delivering electricity, it heats up the tissue and destroys the tissue. So with older technology, not focused ultrasound, when people did thalamotomies on both sides, there was more side effects, which is why when focused ultrasound was invented, people did it one side at a time. But we have this study showing that bilateral thalamotomy with focused ultrasound is safe in a staged manner. So more and more people are getting both sides treated with 9 months apart. So we do have a pretty large number of patients who have had that done in Penn. Now, for Parkinson's disease, it is also being used to treat tremors as well as dyskinesia symptoms with focused ultrasound. So on the left, you have thalamotomy. On the right, you have a publication for globus pallidus. Globus pallidus is another target in the brain that is being used both for deep brain stimulation and focused ultrasound. So in deep brain stimulation, we use globus pallidus target to treat symptoms like dystonia, dyskinesias that are associated with Parkinson's. Now, in focused ultrasound, we use the pallidal target for patients who have fluctuations in symptoms with dyskinesia symptoms as well as tremors. So again, there are large studies showing that, well-designed studies showing that there are good outcomes using focused ultrasound treatment in Parkinson's disease. This is just a chart showing the growth of focused ultrasound over the years. Up to 2022, you can see that it's been getting more and more popular. Patients actually come to the clinic asking for focused ultrasound, whether they are a candidate or not. And for essential tremor, in the last few years, is actually even more popular than deep brain stimulation. That's the growth of focused ultrasound we're seeing in our clinic as well. So what happens in the patient's perspective? What happens during the procedure? So when you come in, first thing we have to do, actually, ironically, we do have to shave more hair in this procedure as compared to deep brain stimulation. In deep brain stimulation, essentially, we can make a very small shave for you where we need to make the incision only. Now, for focused ultrasound, if you recall the picture I showed earlier, the beams have to come in all directions to converge at a certain point. And ultrasound doesn't like air very much because it would deviate the beam, and with hair, it would trap air. So that's why unfortunately, we have to shave all the hair in order to proceed with this procedure. So first thing you do, we'll shave the hair for you here in the hospital. We'll put on a frame, which is the same frame as we do in deep brain stimulation. We do all the planning beforehand with the MRI and CAT scan, as Dr. Halpern has shown you. You know, we use the same high quality imaging for focused ultrasound planning purposes. And then once the frame is on, you go into the MRI machine. Everything is done in the MRI machine. So you will be going in and out of the machine. We will give a sonication. Sonication is a treatment with ultrasound energy. So when we give the sonication, we will test to see whether you have improvement. We do it again, usually about 3 to 4 times on average. So this is an animation to see.
During the treatment, you will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects. During the treatment.
Okay, so again, some of the benefits of focused ultrasound, you do get immediate and durable tremor improvement. It's a 1-day outpatient procedure. You go home the same day. We usually do a MRI right after the procedure to make sure everything's okay in the brain and there are no complications in the brain. We get a physical therapist to work with our patient, and then they usually go home on the same day. Now, one thing we always tell patients, though, is that because of the way focused ultrasound works, which is different from deep brain stimulation, with the ablation, patients tend to have more swelling after the treatment. So we tell all patients to expect some side effects when swelling happens, and this include things like tingling, numbness, gait instability, and speech difficulty. And that happens when there's swelling that happens over the next few days. And this, most of the time, it goes away as the swelling settles down. So this is one of the examples of our patient that received focused ultrasound treatment. You can see the pre-treatment and post-treatment spirals, and he was not able to drink from a cup previously, and no problems after that. So who is eligible? These are FDA-approved indications using focused ultrasound. So both for essential tremor and Parkinson's disease, as I've mentioned earlier. And one thing to note is that, as I mentioned, everything is done in the MRI machine. So if the patient has any contraindication of being in the MRI machine for about 1.5 hours, that might be a problem. And, you know, you can always let us know when we see you in the clinic to discuss, you know, is focused ultrasound a good option for you? So I've mentioned this, what to expect. So at Penn, we are a very high volume center. We are almost reaching our 600th case this year, second highest volume in the world, I believe. We are very excited to be able to offer this technology to our patients. And I think we take pride in being able to offer different options for patients. So like Dr. Halpern said, you know, patients who may not have a good outcome from first treatment, we are always happy to review to see whether we can optimize the treatment, whether it's, repeat focus ultrasound, whether it's focus ultrasound to DBS, whether it's DBS, and considering other options, just like the case study I presented, DBS first, and then considering other options. We are proud to be able to offer all these options to patients. And I think even though, we know that it takes time, it takes, regulatory hurdles, we are willing to do it for patients, and we all look forward to being able to offer the patient the best option to give them the best outcome. So I think that's what we take pride in here at Penn. So some of the things that we've implemented with focus ultrasound is using advanced imaging for targeting. Not every site do it, but we, again, we like to be able to do the best for patients. So we use advanced imaging for targeting. So we use tractography methods to help us segment the actual target. As I mentioned earlier, we need to be as precise as possible because we don't want to make a big lesion that causes side effects. So we want to be as precise as we can. We recently published our methods of doing focus ultrasound here at Penn to share with our colleagues. We also looked at patient satisfaction. As you can see, we take into consideration what patients tell us when they receive this treatment, and we like to improve our methods all the time. So what we found was that when patients were not satisfied, it's when they have long-lasting side effects, or they did not have sufficient tremor relief. So these are the two main factors that would make the patient not happy after the treatment. So we are, again, always looking for ways to improve, by minimizing side effects and improving tremor relief. So how to choose between focus ultrasound, deep brain stimulation? When you come to our clinic, we will have a full discussion of whether you're eligible for one of this procedure, two or both of this procedure. If you're eligible for both, how to make a decision. So, all this we will, if you come to our clinic, we can have a more in-depth discussion than, just talking over online. But some of the considerations that we think about is your symptoms that you have, whether you're looking for one-side treatment, both sides treatment, again, MRI compatibility, whether you're looking for something that's titratable, meaning adjustable, or, something more permanent. And what is your baseline function and comorbid conditions that may, affect the type of treatment that we would recommend. So I think this is my last slide. This is basically a YouTube video that you can find online on Penn in one of our patients using focus ultrasound. So I'll stop my screen share, and we can take some questions.
Okay, we did have some more questions. Someone asked, can DBS and focus ultrasound be done if the person with Parkinson's has a cochlear implant?
That's a very good question. So we similarly, like the case study I showed, we did some modeling exactly for a patient with cochlear implant. So it depends, because cochlear implant causes a lot of MRI artifact. So around the cochlear implant, essentially the MRI will be degraded. So we looked at one patient who had cochlear implant on one side, and I believe that we were hoping to treat the other side. And when we did the simulation or the modeling with our MRI, it was actually possible to treat. We were able to see the structures well with the MRI because the artifact was just outside where we were going to treat. So again, it's case by case. If we are able to get good quality MRI, if it doesn't affect the treatment, if we are talking about focused ultrasound, it cannot affect our beams, our ability to see clearly during the treatment. So if the artifact doesn't affect, potentially it's feasible. And then, there are the other things about, whether regulatory wise they allow us to do cochlear implant in MRI machine for focused ultrasound. Again, it's a lot of regulatory stuff. Now for deep brain stimulation in a cochlear implant patient, as long as we can get a good quality MRI to do the planning, it should not be a problem.
And then we have two questions that I believe you've covered. Focus ultrasound is now available on both sides because it used to only be on one side. So I think that was when you said that's now from 2022 that happened.
So that's for essential tremor.
Okay.
Essential tremor, you can do both sides in a staged manner. For Parkinson's disease, as of today, it's still one-sided treatment. But, you know, I'm sure there are a lot of interest and research going on to eventually have both sides treatment for patients available.
And then it was also asked, is focused ultrasound a permanent procedure?
Yes, so the intent is always one procedure with the effects being long-term. But, you know, it's hard to say that it's hard to promise patients that it's going to last 30 years, for example, because the technology has only been around since 2016. The published results, it's up to 5 years now, but in research realms, I know that there are sites who have had patients for about 10 years. But beyond that, you know, we think that it's permanent. We think that if you have good outcomes at 1 year, it should be a long-term outcome benefit.
Then I have two of the same question. One's just a little bit more specific. The first person asked if a person has a DBS implant, can he have focused ultrasound? And the second person said if a Boston Scientific bilateral IPG has been implanted, can focused ultrasound be safely used?
Okay, so great question. So like a case study I showed, so we have done a lot of modeling. In our opinion, we think it's safe to do. So the modeling we did is if the patient had DBS on one side and we want to do focused ultrasound on the other side. So that seems to be feasible, seems to be safe. Now, but you know, in medical world, we need to be very careful and extra stringent, which is why there are a lot of regulatory hurdles to go through. But like I said, you know, I think there are one or two cases in Korea that's been done now. For our particular patient that we model, we think it's feasible and we will try to have this done soon for patient. The question about whether if you have a Boston lead and you want to do focused ultrasound. So the question is, you know, where is the lead? Where is the focused ultrasound target? Because if they're too close, maybe it's not possible. If they are opposite side, maybe we need to do some modeling to see. For the second question, which is both Boston on both sides. So I'm assuming that patient has one electrode on one brain, the other electrode on the other brain. Now, again, we need to model, but the chances of it being successful will be lower. The reason is because for focused ultrasound, like I said earlier, we start off with 1,000 beams to work with when we converge the beams. What we do in the modeling that I've been talking about is that we actually mark out the DBS lead and we tell the machine, now don't pass ultrasound beams through these areas where there is DBS lead because we don't want anything to happen to the DBS lead. Now, if you have DBS lead on both sides, it tells us that we need to mark out a large area to say no ultrasound being passing through all these elements. That tells me that, you know, I may end up with much less elements than 1,000. Then it'll be less efficient. So the chances of doing focused ultrasound when a patient has both leads in is much lower, I would say.
Well, we are out of time. I thank both Dr. Halpern and Dr. Q for this incredible presentation, this explanation. This recording will be available tomorrow, and Dr. Halpern has graciously agreed to share his slides. I'll follow up with Dr. Q if she can share her slides as well. We have a tradition here at PMD Alliance, our wave of gratitude. Also, we did put their information in the chat. So if you want to save your chat, if you click on the 3 dots, you can save your chat to keep all that information. Thank you so much for being here. We're so grateful that you were here today, and we hope everybody has a wonderful rest of your day. Bye,
Thank you so much for
everyone.
having us, Eden.
Thank you.